volume up, okay.
Okay, so it is my pleasure to introduce Colette Ridehalgh. I hope I got your name correct.
Ridehalgh, it's not bad.
Again?
Ridehalgh.
Ridehalgh, okay. I did my best. I googled the pronunciation, but so she's affiliated with the School of Health Sciences at Brighton University and at BSMS, and today she's going to be telling us about a new project using MRI to look at neuroinflammation and whiplash. So over to you, Colette.
Lovely, thank you. So as Chris said, I'm a lecturer still at principal lecturer at University of Brighton, and then I in a mad moment, I think, was persuaded to come and do research, senior research fellow for this project, which actually I'm really, really excited about. So I'm really delighted to be part of. So my background really, obviously, is within physiotherapy, but all the work I've done really in the last probably 15, 20 years has been about nerve-related musculoskeletal conditions, mainly actually in lumbosacral radiculopathy. But when this opportunity came up to be part of this study, even though it's a slight shift to whiplash, I thought it was definitely worth giving a go. So I'm going to talk a little bit about the project, and obviously I'm talking to you thinking about the MRI scans, but I thought it'd be useful to give you just a bit of background about where this has all come from. Now, are you seeing my slides, or are you seeing the slideshow? Because for some reason it's not. The slideshow? I did. It's not showing it on me.
Yeah, it needs to be in full screen. There we go.
Yeah. Okay. That's okay. So, in terms of the study team, it's a versus arthritis funded study, and we're linking closely with Oxford University. So it's going to be a 2-site study over 3 years. As you all know, Andrew Dilley's the principal investigator. And then we've got a number of important co-investigators. Myself and Joel are the 2 research fellows on it. Jane Greening, some of you may know, she's been involved quite a lot with Andrew in the past, and they did a chronic whiplash study a couple of years ago using MRI. Anina is the PI over in Oxford. And then you all know Mara and Rupert as part of the co-investigators as well. So a little bit of background about whiplash. I'm sure you all know that it's an injury to the neck that results from this sudden cervical acceleration, deceleration movement. Certainly pre-COVID in the UK, there was over 500,000 recorded incidents of whiplash annually. And selfishly, we're hoping that number is going to pick up again. Not that I'm really hoping there's lots of people with lots of pain, but it would help our recruitment if people did start having more whiplashes again. The numbers are creeping up, especially in the last sort of 2 or 3 weeks. Interestingly, there aren't really very many classification systems for whiplash-associated disorder. This one is by the Quebec Task Force, and this is back in the 90s now. And there's basically 4 main classifications of whiplash injury. What we're particularly interested in is the second disorder, so WOD2. And in this particular disorder, we would consider this to be relatively mild. So there are musculoskeletal signs, including decreased range of movement and point tenderness. But really importantly, there shouldn't be any evidence of any involvement of the nervous system. And certainly on routine clinical examination, we shouldn't pick anything up. Whereas obviously 3s becomes a more significant injury with involvement of the nervous system, and 4 would be more of a fracture, so a much greater kind of traumatic event would have happened. Of those WOD2 patients, around 50% of those will go on to develop these persistent pain states that we see. And it, unsurprisingly, like many of the persistent pain states that we see in society, they have this real considerable financial burden. And they're really made up of a mixture of healthcare costs, but also compensation payments. And it's a fairly whopping £3 billion per year to the UK economy from whiplash associated disorder. So it's pretty significant. And one of the big issues is that there really is a lack of clinical evidence for these conditions. And there really isn't very much guidance for diagnosing this particular condition as well. So it's quite challenging when it comes to dealing with patients. And also, as you probably all know, compensation payments have been considerable over the years. And there's been just a recent change to compensation, I think at the end of last week. So that might change things even more moving forwards. But suffices to say that if you go into an emergency department now with a whiplash injury, you probably won't hear the words whiplash injury because of these big issues related to it. So despite the fact that we don't really see this nerve injury on a routine clinical examination, there's quite a few different factors that might suggest that these people with WOD2 actually have a neuropathic pain condition. So there's a number of different parameters that we can look at, and cutaneous sensitivities to tactile and thermal stimuli. So in other words, you become acutely aware of light touch perhaps to the skin. It becomes almost a pain stimulus rather than a pleasant touch. That would be allodynia. Or you would have an excessive painful response to a noxious stimulus. So for example, if someone stuck a needle into you, it would be excessively painful. Or heat and cold might be really painful. People sometimes will talk about sitting in a cold draft actually giving them a lot more pain, and that would be considered to be a hyperalgesic response. The other thing that you might also see is this loss of sensation, and particularly seems to be affected the small nerve fibers. So again, warm and cold might be particularly affected. So you could have this heightened response, or you could have this loss of response to those kind of stimuli. There's some really lovely studies looking at the density of nerve endings within the skin using skin biopsies. And again, in a fairly recent study on people with whiplash, it seems that there are absence of these small nerve fibers in the periphery. Something else that we look at quite a lot as physiotherapists is the sensitivity of nerves to movement or to touch. And again, this seems to be the case in people with WOD2. So this concept of nerve trunk mechanical sensitivity has been used quite a lot in Andrew and Jane's previous work, but also actually in my PhD looking at lumbosacral radiculopathy. But in terms of WOD2, again, if you push over the nerve trunk, so even away from the site of injury within the arm, in patients with whiplash, what you tend to see is this increased sensitivity over those nerve trunks. Interestingly, they can be sensitive bilaterally, but probably unsurprisingly, it seems to be worse over the symptomatic side itself. And then as well as actually these points that you can push on to see whether they're sensitive, we can do these particular movements, joint movements, a series of different joint movements that will stretch the nerve trunks themselves. So many of you will know straight leg raise tests for lumbosacral radiculopathy. These tests we can do similarly in the upper limb. And the idea is that you add a series of joint movements, and that will impose a number of biomechanical changes on the nerve, including just excursion or movement of the nerves. And then as you get to the ends of range of movement, we get this strain or stretch on those particular nerves. And they've been looked at, these tests have been looked at quite a lot in cadavers. We've also looked at it with ultrasound imaging, and really nicely, again, Andrew and Jane have done a lovely elastography study looking at shear wave elastography. And what this kind of technology enables you to look at the velocity of the shear wave that's propagated along the nerve. So we can see in that upper blue image, in the flexed limb position, this is of the median nerve, we see much lower velocities, whereas as the limb becomes extended, I'm sorry, I'm aware I'm a little bit short for this camera, but as you stretch out the arm like that median nerve tension test, the shear wave velocity increases, and that's basically an indicator of nerve stiffness. So at these ends of ranges of movement, we get this elongation of the nerves, stretched, increase in stiffness. And again, when we look at these particular tests in people with a variety of different conditions, but particularly in whiplash-associated disorder, we see this symptomatic response to those particular movements. Again, can be bilateral, but tends to be worse in the symptomatic side. So what we're really proposing in this study is that some patients that are diagnosed with WOD2 actually do have nerve involvement, but they aren't necessarily being detected on some of the routine clinical tests that are currently being performed. And one of the main thoughts about this is that this could be being caused by peripheral neuroinflammation. And this really stems from a whole host of animal work that Andrew's been doing over the last many years. Not saying anything about your age, Andrew, but you know what I'm saying. So I think this is really fascinating work. This kind of model is quite different from some of the other animal work looking at neuropathic pain states. Quite often that they'll impose an injury to animals that causes quite a lot of damage to the nerve, so axonal degeneration. In this model, they use a substance that actually just causes this neural inflammation, but the nerve itself remains intact. But what they do see, and these little graphs that you can see here, are all about the way in which the animal responds to a particular stimulus. So on the left, we have this poor little rat's foot being prodded with a von Frey filament. So it's just like a little nylon filament. And what you do is you prod it until the animal kind of says that's enough, and it withdraws the paw from that particular filament. And as we can see here on the left, when we're looking at the animals without any neuritis, they have relatively high thresholds. So it takes about 14 grams of force before they lift their paw off that stimulus. But with a neuritis model, that dramatically reduces at around 3 to 4 days. So the animals are withdrawing their paws at much lower stimulus, suggesting that they have this mechanical hyperalgesia. The other way we can look at it is to actually apply a heat stimulus to the bottom of the paw. And again, just look this time at the length of time it takes for the animal to withdraw that paw from the heat stimulus. And again, around about 3 days, we see this massive drop in that latency, so a decreased latency, indicating that there's this thermal hyperalgesia. Something else that's really interesting is that, remembering that these nerves don't have any significant injury to them, they're simply inflamed, is that they can also start to spontaneously fire. And this is seen really commonly in neuropathic pain conditions, but often we kind of contribute that to this much more significant change of or structural degeneration of the nerves. So it seems that it's possible, you know, long before those nerves become more damaged, for want of a better word, that they become really oversensitive and spontaneously start to fire. So the aim of this study really is to look at this in humans. So we're translating those animal studies into more clinical studies, and also continuing the work that Andrew and Jane have already done on this in those patients with chronic whiplash. So we want to know whether there's this contribution of peripheral neuroinflammation in patients with WOD2 and what its role might well be in prognosis. So there's 4 objectives to this study. The first is just actually to try and determine the presence of peripheral neuroinflammation during the acute stage following a WOD2 injury. So we're going to be recruiting patients within 4 weeks of injury and looking at these MRI scans that we'll talk about in a minute to try and assess the extent of peripheral neuroinflammation and also any changes in nerve microstructure. And then to assess whether this presence of peripheral neuroinflammation in the acute stage actually goes on to predict chronicity. So we're going to get people, look at people 6 months after their injury and look to see whether these measures of neuroinflammation predict that patient status. We're going to be using something called a neck disability index to give us a measure of recovery or not recovery at 6 months. And then to determine what's actually happening from that acute phase to the chronic stage of whiplash associated disorders to injury. I should just use WOD2. It's a big mouthful. And we'll look at those changes in MRI measures, and also we're doing a whole heap of clinical tests, which I'll tell you about in a second, at 6 months in the recovered and the non-recovered patients. And then finally, and I think this is a really important part of the study, we want to know whether some of the cost-effective clinical tests that we're going to be doing during this study can serve as markers to detect neuroinflammation as determined on MRI. So this is how it's looking. So it's a prospective observational longitudinal study. As I've already said, it's a 2-center study. We're hoping to recruit about 115 patients with WOD2 and 32 healthy controls. And then we're going to be running both those MRI and clinical assessments in both of those groups. And then in the patient groups at 6 months, we'll be looking at their change in their neck disability index, and then following up 25 of those that have recovered and 25 that haven't recovered, to see if we can really unpick this association between neuroinflammation and prognosis. So we're basically, in a nutshell, looking at for patients between the age of 18 to 60 with neck and arm pain following a whiplash injury. We don't want people with major trauma or any major comorbidities. I'm not going to go through all these inclusion-exclusion criteria. They're probably what you're expecting to see. It basically sums up what I just said in the previous slide. So these are some of the assessments that we're going to be doing. So clinical examination, we're looking at symptom history. We're going to look at range of limb movements, and your standard neurological examinations looking at sensation, muscle strength and reflexes. We're going to be looking at quantitative sensory testing, so a bit more detail about the way in which these small and large fibres are behaving, or are functioning, I should say. So that will give us a mixture of both loss of any nerve sensation, but also any gain, so any of these hyperalgesic or allodynic type measures. And then we're going to be looking at pressure over some of these upper limb nerves, as well as looking at these upper limb tension tests. We're also going to be doing blood tests to look at serum inflammatory proteins. And obviously, we're going to be looking at some questionnaires. These are just 3 of some of the ones we're looking at. So we're looking at pain detect as a measure of neuropathic pain. Neck disability index is really going to be what we're using to work out whether our patients have recovered or not. And another one we're going to be interested in is in post-traumatic stress disorder. And then coming on to magnetic resonance imaging, and we're going to be looking at both brachial plexus and the wrist. So we're looking at T1-weighted images to assess for nerve morphology, and then T2-weighted stir. This is really to give us that ability to look for any peripheral neuroinflammation. So these are slides from the study I talked about previously that Andrew and Jane did, looking at patients with chronic whiplash. And this is the T2-weighted image, and what we can see from the control at the top to the patient at the bottom is this real increase in signal intensity at these at the brachial plexus, particularly C5, C6 brachial plexus seem to be the those particular nerves that were most bright in this study. And then on the right, we've got the median nerve within the carpal tunnel syndrome. So again, the control on the top and the patient at the bottom. And what was fairly consistently seen was this, again, increased brightness at the carpal tunnel, which is obviously significantly a long way away from the brachial plexus. So again, this increase in signal intensity. Also really interesting, this flattening of the nerve within the carpal tunnel, which looks a bit similar to patients with carpal tunnel syndrome, but these patients had no history of carpal tunnel syndrome. We're also going to be looking at some diffusion tensor imaging as well, again, both at the brachial plexus and at the carpal tunnel, to give us an idea about the integrity of the axons and the myelin sheaths. So this is the scanning sequence that we're going to be using for the brachial plexus, hopefully when we can get hold of the 3T scanner. We were supposed to be running some some sequences this afternoon, but unfortunately the leaking roof has put a stay to that. So we're hoping to get back in there as soon as possible. So I won't go through all the parameters for you, they're all there. So we're looking at a 64 channel head and neck coil though, and we're looking at these 3 sequences there. And then for the wrist, we're doing this reverse Superman position. So it's a really awkward position that we're going to have to use with patients. But we had a play around trying to do the same thing. In the past, they've tried with the arm by the side, but that's not worked very well. So in Superman in prone, but because a lot of these patients are going to have neck pain, we just don't think they're going to tolerate lying in that position. So we're going to try and pad them up on their backs, really supporting their arms so that we can have them in this position. And we're doing these following sequences on those patients. And then afterwards, we'll be looking at these analyses. So we're going to be looking at nerve signal intensities for the T2. We're going to look at area and aspect ratios of the nerve. And then we're going to be looking at fractional anisotropy, mean diffusivity, and radial and axial diffusivity. So quite a lot of analyses to be doing afterwards. I'm not worrying about this just at the moment. I'll leave that until we start getting some patients in. So why are we doing it? Well, the potential impact of this study is really thinking about that changing classification of WOD. So it's a very outdated classification. It doesn't seem to be particularly helpful. We're hoping this might help towards a newer, improved way of classifying patients. It might well be that MRI could be used more routinely to diagnose peripheral neuroinflammation, not to diagnose whiplash disorder, because that's kind of not really been very helpful in the past. I think again, really importantly, if we can really work out whether some of these bedside clinical tests can indicate this peripheral neuroinflammation, that's going to be really helpful for people in the future. Like everything, you know, it's the same with the work I've been doing on patients with spinally referred leg pain. We really need much better stratification of patients in order to better target treatment. It might well be that we can start earlier intervention strategies with these patients to try and prevent the chronicity that seems to be occurring in 50% of these patients. And obviously, really importantly to me, it might well be that we could start earlier rehabilitation programs on people if we can control pain and help with that inflammation in the early phases of a WOD2 injury. So this is just to summarize what we're aiming to do. These are the measures that we're going to be doing. And that is the end of that. So thank you very much for listening. And please let me know if you've got any questions. I think there's already...
These are claps.
Oh, they claps. Oh, I was thinking that was a hand up. I was going, oh my gosh, that's quick. That was quick. Give me a minute. Right, let me just stop sharing. I can't speak. Stop sharing.
So I have a question. So you're doing this over multiple sites with different scanners and things like that. Do you know of any issues with the fact that you're acquiring on different scanners with different coils and presumably going to try and get the sequences the same, but if you're going to be collapsing these samples into one big analysis, are you doing anything to make sure that they're the same, or are you keeping separate samples?
Yeah, I mean, it's a really good question, and it's certainly something before COVID that I think there was the plan to do a bit more looking at phantoms and also looking at images and comparing them, and we haven't really been able to do so much of that because of COVID. But certainly, we're still going into the scanner. At Oxford, they've been running these sequences again on each other, and the idea is that we'll start looking at them and comparing them to see if we are seeing any differences. Obviously, we can't adjust for that on the scanners, but we could adjust for that afterwards if we're seeing any particular trends in one direction or another, any of these particular measures.
Are you going to try and acquire like this a subset of both patients and controls in the different centres? So
yeah,
no. Necessarily you could just do
not patients but controls.
Okay.
And we're looking at ratios. Yeah. Oh, sorry. So we're normalizing to other tissues within the body. So again, that should help us to try and deal with any differences.
I see. Does anybody else have any questions?
You mentioned something about PTSD, and I'm assuming that that's just to kind of document it rather than having specific hypotheses and so on.
Yeah, absolutely. I mean, I guess we just don't know. These could be people with fairly minor whiplash injuries, or these could be people with what we might consider fairly minor whiplash injury, but it might have been a very traumatic event associated with it. So it's certainly something we could look at in terms of an analysis later to see, you know, if there's a covariant that might have any influence on outcome. But we just don't know that at the moment.
What about pain? It's all catastrophizing is often the other one, isn't it? Is that, I can't remember whether you listed that, but that's a big predictor of neuropathic pain. Yeah,
we are looking at pain catastrophizing scale as well. So that'd be another one that we'll throw into the mix. It's really interesting, actually, I think, with when you're looking at some of these psychological and social factors, they aren't consistent in terms of how much they predict chronicity. But I think it's really important to have them in there as well. Just to give us an idea about whether these are particularly prevalent or problematic, I should say, in our cohorts.
I mean, I could ask another question, and that's around whether or not you would do any kind of open science up front about this or not, because when you've got something that can be explored in a million ways, you know, that's great at one level, but it can also, you can trip yourself up with it as well, and it's an awful lot of work to do it. But I wonder where your thoughts are with this.
Do you mean you're kind of like just throwing in multiple variables into an analysis and hoping that you'll pull something out at the end of it?
Yeah, and that's kind of okay, provided that you're transparent about these are the analyses I'm going to do. And then if you do extra ones, then that's kind of fine, because people kind of know that they're extra or that they're post hoc. Because the problem is that you can't necessarily tell which are the planned ones and which are the ones that this looks promising, let's have a closer look at that. Which to some extent okay, but you just need to be clear about what you're doing.
Yeah. And actually, I might have to call on Andrew to help me out here, because obviously he had planned, all the power analysis has been done on very specific variables for the analysis, isn't it? Did you want to come in and just comment on that?
Hi, Jamie. I'm here. Yeah. No, that's a brilliant question, and Stephen Bremner is involved with this as well as statistician. We had multiple conversations. We were kind of coming up with a study about what our measures would actually be, and you're absolutely right. It's the problem that we had, that there were so many different things we wanted to look at. We have narrowed it down. As far as I'm aware, all of the questionnaires that we're doing, including the pain catastrophizing questionnaire, they are planned measures for this study. We have allowed for that at this stage. You're absolutely right. We're going to end up with tons of other measures as well, which would also be interesting, but as you're saying, could trip us up at the same time.
Okay, cool.
I think perhaps one of the things that Jamie might be suggesting here is that you think about doing a pre-registered study. So you actually submit a pre-registration now about your analyses, and then you can have that be documented in the public sphere, and you can still do your post hoc analysis afterwards as well on top of that.
That brilliant idea. You know, I hadn't thought of that, but that is, you know, now you're sort of raising this now. I think absolutely something we should be doing. I agree. We can certainly look into it.
You could also have what's it called, an embargo on it. So
you're right. Yeah, embargo.
Yeah. This sort of.
Let's make a note of that.
Thanks, Jamie. I can't decide whether to keep my mask on or take it off. No, my glasses are steaming up.
So I get mine on, that's fine.
We live in interesting times. I wonder if there are any more questions. If not, then I think we should perhaps wrap up. Yeah, thank you very much. It was a very fascinating talk, and I think perhaps the time of year we didn't get the attendance we usually get, but it will be on. If it's okay with you, I can post it on the Sussex Neuroscience YouTube channel, and people will watch it later.
Yeah, that's fine by me. I'm happy with that.
Yep,
yeah.
Fantastic, wonderful, and thank you everybody. This is actually the last CNI of the summer term, so we will resume again in September. And lovely to meet you, Colette and Andrew.
Yes, Andrew. All right. Thanks a lot.
Thank you.
Bye.